Good afternoon, everyone, and welcome. I am Dr. Karen Brown. I'm the Dean of the UVI School of Education, and I am so happy to be here. I'm happy to see so many of you joining us, and I look forward to us learning together today. I have the distinct pleasure of introducing our presenters today. We have Dr. Joanne Bodertha, and she's the co-project director. And first of all, let me pause. Can you hear me okay? If you cannot, then please feel free to unmute yourself or send it in the chat and I will make a change. Excellent, thank you. And so what I'm going to do is go ahead and mute everyone. Good afternoon. I will begin again. So I have the distinct pleasure of introducing our presenters for this afternoon. And I will begin with Dr. Joanne Bodertha. She's the co-project director for the New York Mid-Atlantic Caribbean Regional Genetics Network. It's also referred to as NIMAC. She is a professor of genetic medicine, pediatrics, and oncology in the McKusick-Nathans Department of Genetic Medicine at the Johns Hopkins School of Medicine, with appointments in the Department of Health, Behavior, and Society in the Bloomberg School of Public Health and the School of Nursing. She transitioned from Virginia Commonwealth University in 2011. She received her BA from Swarthmore College and her MD and MPH from Yale University. She did a year of research at the Nagasaki University School of Medicine as a Luce Scholar. Dr. Bodertha completed her residency in pediatrics at Children's Hospital of Philadelphia, also referred to as CHOP, and worked as a U.S. Public Health Service physician on the Turtle Mountain Chippewa Reservation in North Dakota. She completed her medical genetics fellowships at VCU. Her career goals are helping make genetics work to help individuals and families and helping communities be welcoming to persons with disabilities. Next, I have Dr. Mitzi Payne. Mary S. Mitzi Payne is a professor of neurology at the Joan C. Edwards School of Medicine at Marshall University and a member of the Division of Neuroscience. She earned her medical degree from Emory University School of Medicine. Dr. Payne continued her training in pediatric neurology, completing her residency and fellowship at Louisiana State University School of Medicine in New Orleans. She has a special clinical interest in seizure disorders, muscular dystrophy, and cerebral palsy. Dr. Payne is a member of the American Academy of Neurology, and she also provides services right here in the U.S. Virgin Islands. She'll tell you more about that. We have Maria Isabel Frankenberg. She's a diversity and equity professional. She has worked extensively to improve meaningful access to education and healthcare for Latino, recent immigrants, and other underserved populations. She is currently the co-executive director of Bogota Global Engagement Firm, LLC, where she guides organizations as they move to meaningfully engage underserved communities to open access to equitable healthcare and education. Maria Isabel holds a LEN, that's Leadership, Education in Neurodevelopmental Disabilities, certificate from Virginia Commonwealth University, where she was the first parent of a child with a special healthcare need to be invited into the program. Later on, she became LEN faculty teaching interdisciplinary teamwork. Concurrently, Maria Isabel worked at the Virginia Commonwealth University Center for Excellence in Developmental Disabilities. So it's the Virginia USED, similar to the VI USED that you see here in St. Thomas and St. Croix, and the Family to Family Health Information Center, spearheading outreach and engagement efforts to the Latino and other immigrant communities. She holds a Bachelor of Arts in Philosophy and Political Science from the University of North Carolina at Chapel Hill. She's a native Spanish speaker from Colombia and is fluent in English following her 30 years of living, studying, parenting, and working in the United States. Last but not least, we have Alyssa Terry, who's a board certified genetic counselor in New York State and has been working with the federally funded New York Mid-Atlantic Caribbean. Again, remember that name is NIMAC, Regional Genetics Network for the past 6 years. Currently, Alyssa serves as the project manager and telegenetics navigator for NIMAC. Alyssa received her BA in biology from Cornell University and her Masters of Science, in genetic counseling from Johns Hopkins University. Alyssa has worked in various capacities for the genetic counseling program at the Ferrer Institute since 2006. So you're in for a treat, and without further ado, I would like to introduce again or have Maria Isabel Frankenberg join to present to you.
Thank you very much, Dr. Brown. It's always a pleasure to be here with you, and I'll be very brief. Thank you for that wonderful introduction. It is in fact the AUCD network, the USET network where we met, and that is where Dr. Bodertha and I met. And that is how, after a trip here to the Virgin Islands for SICA work and to set up the family-to-family health information center, has always been by the hand of Dr. Brown. So I thank you very much, because if it weren't for you, I think all of us would not be here. So thank you to you. And
for those who don't know, AUCD stands for
Association of University Centers on Disabilities, and that is a national network where all the USETs from all the states, as well as the lands, belongs to the Technical Assistance Center.
Right, and there are 67 USETs in the US and its territories, and at the University of the Virgin Islands, we are one of them.
Correct, that is right. And so for all sisters and brothers, please be part of the USET here. So with that, I would love to introduce Alyssa Terry, who will tell us all more about NIMAC.
Good morning, everybody. I want to make sure people are seeing the slides. Can someone tell me in the chat if you're seeing the slides? Not yet. Okay. So we need to share screen. How about now? Can you see the slides now? Great, perfect. Thank you. Thank you for playing along. Make your pictures bigger though, so we can see you also. Okay. I'm trying to figure out how to advance this. Okay, that does work. Perfect. Okay, so thank you for Dr. Brown for introducing us. You can see our names there. Again, today I'm going to spend just a couple of quick minutes talking about who NIMAC is and who we are, and then I'm going to hand it back to Dr. Brown to talk about Learn the Signs, Act Early. After that, Dr. Bodertha and Dr. Payne are going to talk to us about some family stories, some patient stories about times when developmental milestones were related to a genetic diagnosis and what that really meant for the family in terms of being useful information to them, either medically or for their own planning purposes. Oh my God. Uh-oh. Okay. We are going to have you do a very quick survey before we get started, just so that we have a sense kind of going into this together about how people might think about genetics. So you can either use the QR code there or the link to answer. I think it's only 5 questions. So I'll give you like 2 or 3 minutes to take that and just give us a little bit of a sense of how you're feeling about genetics. And then we will move on and talk about who NIMAC is. So if you could do us a favor and take care of that, that would be wonderful information for us to start with. Oh, they said they're not seeing the presentation. All right, let me reshare. Okay, now you should be able to see a QR code and a link on the screen. Let me know in the chat again if that's not coming up. Okay. Sorry about that. All right. It was just a couple quick questions, so hopefully enabled access. I'm going to type the link in the chat so that people can just click it if they want. Okay, hopefully that works. I'm going to keep moving along, but it should be pretty easy to just answer those questions quickly while I'm kind of introducing NIMAC. Just let me know if you have any other problems with that. Well, I'm going to try a new kind of screen share because this is not letting me move the slides. So let me try this again. Yeah. Okay, it moved. Okay, thank you for bearing with us while we figure this out. I think we're good now. So one of the questions we always ask people when we come to talk about genetics is sort of why genetics? Why does this matter to this group of people that we're working with today? So some health challenges we know can be caused by changes in our genes, and genetics providers hope to help families learn whether genetic changes could explain the health conditions in their family and work together with the family to provide the best possible care. So I'm curious on the call today, if anyone wants to put in the chat if they've ever suspected that any health condition might run in their family. Is that something that people have ever thought about? That's something that maybe your mom or dad or your sister or your brother or your child had, could have been something that was running in the family. Is that something that people think or talk about? And just if anyone wants to put anything in the chat, we're trying to keep an eye on that. So in our last few days that we've been in the Virgin Islands, and thank you all for having us, by the way, down here. We're in St. Thomas today. Some of the things that people have talked to us about, the nurses and the families we've met with, are things like autism, sickle cell disease, developmental delays, intellectual disabilities, deafness or hard of hearing, blindness or low vision, and some of the other conditions that you see there on the screen. So these are things that a lot of people talk about in their families, even things like cancers and heart disease, things a lot of us experience. And sometimes people wonder whether they might be more likely to experience those conditions because of something in their family. So you heard this morning already what NIMAC stands for, New York Mid-Atlantic Caribbean, and we're a regional genetics network. And I'm curious again, if anyone wants to share in the chat, how many people before today had heard about NIMAC or talked maybe with Maria Isabel or Shami Carr or myself before today about NIMAC and what our goals are. So if anyone wants to share in the chat, if you've talked to us before today, it's helpful to know. You see a little map on the side of the screen there with the different colors, and that shows the states and territories that our grant covers. Oh, thank you, Emma. So as you can see, we have 10 altogether, including Puerto Rico and the Virgin Islands, and we're super excited to be collaborating down here in the territories. And every state and territory in the country is covered by one of the regional genetics networks. So the bigger map you see down in the corner shows how other parts of the country, including Florida, where I know a lot of families from the Virgin Islands go, are also covered by a regional genetics network. And our funding comes from HRSA, or the Health Resources Service Administration's Maternal Child Health Grant. And I know some people on the call and a lot of people we work with also receive and work with HRSA funding. So just a tiny bit about who we are. You heard a little bit earlier that Joanne comes from Johns Hopkins. We also have people on our leadership team from the New York State Department of Health, the University of Pittsburgh, FARA Institute, and RTI International. We have an advisory committee that we work with regularly that has stakeholders from across those 10 states and territories I showed before. And here in the Virgin Islands, we've been really fortunate to be connected with people from MCH, educators, newborn screening professionals, people from EDI, the University of the Virgin Islands, people like nurses, hematologists, pediatricians, advocates for sickle cell disease, disability rights, family support networks, the USAID, as we were talking about earlier, and even more. And across all of our states, we really try to keep those collaborations large and diverse and hear from all the perspectives of people that are affected or play a role in genetic services. So thank you for being one of those stakeholders today. So pretty much what NIMAC does is work with local stakeholders. So I mentioned to you those people we were working with. We had a great dinner with people last night. We have another Grand Rounds dinner planned for tonight. We work on telemedicine projects sometimes to bring services to regions that don't have specialists nearby, and do a lot of work around education for families and professionals about genetics or other issues that relate to families that have genetic conditions, and all of that with the goal to make sure that families have access to quality genetic services. So that's pretty much what NIMAC does, both in the Virgin Islands and elsewhere. And this is just a handout that's available on the U.S. Virgin Islands part of the NIMAC website that kind of explains more specifically what our goals are here in the Virgin Islands. So you can find that online. And with that, I'm going to pass it back to Dr. Brown to talk with all of you about what Learn the Signs Act Early is and a little bit about developmental surveillance.
Thank you, Alyssa. Much appreciated. Okay, so I promise not to take long. Okay, so many of you already know some of this, and then so I'm going to continue and provide some information for those who may not know what Learn the Signs Act Early is. It's a campaign that was developed by the Centers for Disease Control and Prevention, and from 2015 to 2022, I served as the CDC's Act Early ambassador to the USVI. So I'm going to go over this information very, very briefly, and then you're going to see the connection between what NIMAC is here to do, the work, and our doctors who will be talking with you after this presentation by me, and how they all connect with Learn the Signs Act Early as well. Okay, so when we're talking about developmental disabilities, about 1 in 6 children have a developmental disability. They're at increased risk for poor outcomes in many areas, and that includes health, their well-being, their overall success in life when they progress academically, that can be impacted as well. There's an increase, it increases a child's risk for poor school performance. They may be absent from school frequently. They may have to repeat a grade, and they may have health problems. So milestones, you've heard this before. Some people may refer to it as domains. These are skills that most children can do. And as I've talked to some of you before, that your pediatrician, your healthcare provider should be engaging you and your young children, their clients, their patients, in monitoring their skills at certain stages in life. And so it's how a child plays, learns, speaks, acts, and moves. You see these every day. And what this campaign is, learn the signs, act early. We are identifying signs, but we're not just identifying problems, we're celebrating milestones when we see them. Less than half of children with a developmental disability is identified prior to kindergarten. That's a problem. It's not isolated to the US. It's here in the US Virgin Islands. As we have learned through those, our local surveys as well, right? We have learned that many of our children are identified for the first time in public kindergarten. And that is really, really too late. Adults, we're not recognizing those signs or concerns in time. And so it does create a problem, because the goal is to identify early enough, or earlier than what we're doing right now. Developmental monitoring, or as Alyssa Terry mentioned in her presentation, developmental surveillance is also the term that is used. And that's usually a term that is used among the healthcare professionals. These are examples of milestones in action. For example, and because of time, and because I'm not just doing the presentation by myself, I usually ask for you to provide some examples of milestones. So for 2 years, a child should be able to copy others, especially adults and other children. 4 years, cooperating with other children. They should be able to, at 6 months, be able to pull themselves up. Before that, should be able to lay on their tummy and roll. When you provide that tummy time, before 2 years of age, they should be babbling, cooing, raspberries, as we've discussed before. Those are milestones. And so one way of trying to celebrate those milestones and identify concerns early on is developmental monitoring or developmental surveillance. So you're noting each child's developmental milestones, you're sharing what you've seen with parents, and you're encouraging parents to talk to their child's doctor if you or they have a concern. Okay, we know we're working with early care and education providers. What I've also done is using these same milestones is when the parents go to see their physician, their child's physician, they have specific information that they take with them, so that no one is saying, oh, leave it alone, they'll outgrow it. They have specific data that they can present to their healthcare provider. So this is what tracking milestones helps you to do. Understand each child's developmental progress, determine if the child needs extra help or additional challenges in a particular area. And again, those milestones are language and communication, cognitive skills, memory, attention, maintaining attention, physical growth and movement, social emotional learning. And the CDC has recently updated their milestones as well. If you want to even look at milestones for hearing, there are milestones for hearing as well. And what we really don't focus on with Learn the Signs Act Early would be pediatric feeding and swallowing. There are milestones when it comes to that as well. So it helps to determine if the child needs extra help or additional challenges in a particular area, and to gather objective information, the data I was talking about, so that we can talk with supervisors and inform parents and healthcare professionals of what we're seeing on a day-to-day basis in those childcare facilities, at home, at school, preschool. Tracking milestones helps parents to understand that watching for milestones is very important. It could be the parent, it could be the neighborhood person who watches the children during the day. It could be a neighbor, it could be an auntie, uncle, it could be a godparent. But it helps them to better understand what milestones are, to get engaged in the practice of watching, observing, looking for those milestones, celebrating them, identifying when there's a concern, and to pinpoint any potential developmental concerns, as I just stated. It's important. It gives you the chance to catch signs early enough, and so that you can provide the earliest intervention as possible through your recommendation, because then we have other professionals. We have occupational therapists, we have our physical therapists, we have speech language pathologists who are also members of the team. We have diagnostic clinicians who do engage with our medical professionals as well to provide early identification and intervention for children who are with and at risk of developmental delays and disabilities. I wanted to provide a comparison between developmental monitoring and developmental screening. So developmental monitoring, it is a formal process, and basically, and it looks like it's been switched, so forgive me. Yeah, the developmental monitoring, anyone can do. The list of people that I provided, anyone can do, and they engage in an ongoing process. Developmental screening, I don't know how that happened. At least on our screen, it's backwards. It's a validated screening tool that we will use to determine if there's an in-depth evaluation that's needed. So from monitoring, you go to screening, and then from screening, you go to an evaluation. I have worked with doctors, developmental pediatricians and neurologists and others as a team member, and we have together diagnosed. Now, as a speech language pathologist, I would diagnose language, communication, feeding disorders, but with a medical professional, diagnose individuals, little ones on the autism spectrum. What else? As an example of a screening tool would be Ages and Stages questionnaire, but there are others. And so towards the end, I just want to let you know that the CDC offers free milestone tracking tools. You can go to www.cdc.gov, act early, or if you don't remember that, you can just go to a Google search and say, type in CDC act early, and it will take you to this site, provides you with examples of milestone checklists that you can use. Doctors who I know have used this as well. They go from 2 to 5 years of age. And then on the bottom right, you can see where it says, or mid part of that page on the right side, to act early if you see some of these concerns. Shows you how to use it. And so I'm just going to skip past this. The not stay or labor on it too long. Milestone Moments booklet provides you with, on the right, how you can help your child's development, how you can provide these free tools to your parents, and they can help their child's development, how you can help the children in your settings to develop in certain areas. Now, if a child is 2 years of age and they're not doing everything that they're supposed to be doing at 2 years of age, I would say that you don't wait till today's their birthday and then you're saying, oh, there's a concern, to even wait more towards right before they turn 3 years of age. But you don't have to memorize anything, because this information is here for you. And it has the social emotional language communication. It has all of the milestones right there for you to look at. You can do it every day. You can print the information. There are growth charts. There's a milestone tracker app that I use with my son. And this is for those of you who find it easier, just instead of having hard paper, that you can use an app. If you have the Samsung, then you would download it from Google Play. If you have the iPhone, then you will go to the Apple Store, the App Store. And whenever, let's say I missed some time, I was too busy, I didn't look to monitor my son's milestone, the app actually reminded me, Karen, look at this. And so that was very helpful. We also have children's books in English and Spanish, and you can actually translate some of these other materials to other languages, Portuguese, Haitian Creole, among others. And you can follow up with me if you need that assistance. I can assist you with that. But with Baby's Busy Day, Where is Bear? ¿Dónde está Osita? Amazing Me. These, as you can see, for the 1-year-olds, the Baby's Busy Day books, it's hard. Babies can, when they're teething, they can mouth these books and they're not going to break away. But the other books, as you get older, for the 2-year-olds and the Amazing Me, that's more for 3-year-olds, they have those checklists in there. And for the Amazing Me, I worked with Head Start once, did a presentation for Father's Day. And they each received their own book, and they had their kids with them in this interactive live presentation. And we read the book together out loud. And as we read the milestones, we were monitoring right then and there, and the kids didn't even know that, about brushing their own teeth. And so they were raising their hands, I can, and they were showing us what they could do. It was really fun. And it also showed parents right then and there fathers for that particular presentation, how to monitor their children's development and what was expected for that particular age as well. This digital toolkit, fact sheets, and just to end, tracking milestones is a great first step in developmental monitoring. We have to share the milestone tracking with parents, including celebrating, not just identifying. We don't start with identifying concerns, we start with celebrating what we do see. We know we want it to be generalizable. We may see it in our classrooms, but not at home, or they may see it at home and not in the classroom. So the goal is to make sure that we see it in every place where the child is within their environment. We talk with parents about milestones that they see, and we act early and share concern. So this is finally, understanding and tracking milestones are important for your job. CDC has free resources. Act early can make a real difference. Here's the email. I'm rushing because I don't want to keep the very important presentations. And so I would like to introduce again Dr. Joanne Bodertha.
Thanks. I have to see I have long enough arms to hit the keypad here. I think I have to pull this in a little bit more. I will put on my glasses because that's one of my genetic issues is familial, presbycusis. So again, we are having, it's old age vision changes. We are having a wonderful time learning so much and feeling so welcomed in the Virgin Islands. So I really want to thank you all for joining with us today. I am a pediatrician first, so very concerned, as Dr. Brown has taught us, about developmental milestones. Have a daughter who's now an adult, so we're kind of in the next stage of that, but really want to have you think about, just for a moment, if you think you've worked with a child with a genetic condition, or maybe you're a parent or advocate who have a child with a genetic condition. We're going to focus on a few stories today of children who have developmental issues along with an underlying genetic basis for that. And so what I'm really asking you today is think about where your ancestry, the children you work with, ancestry hits their horizon, and what that horizon and the milestones going forward are going to look like, and to have your genetic antennae up with the idea that there are now increasing number of conditions, and we're delighted to have Dr. Mitzi Payne with us today, particularly in neurology and particularly in the cognitive and intellectual disabilities arena, where an underlying genetic diagnosis can really make a difference in terms of treatment and management. So again, we often talk about, although we keep looking for another word, red flags. So if you have those genetic antennae up, I'm going to give this example here where hypotonia and motor developmental delays may really indicate more is going on than just a little delay, that there may be some underlying basis for that. And just making the point there that weakness and hypotonia are somewhat different things. And again, you can see the example in the pictures. Again, to back up a little bit in terms of what are we talking about in terms of genetic changes, and we don't want to make this into alphabet soup, but really, again, often an analogy that we use is recipes. And we have the DNA nucleotides, A, D, G, and A, T, G, and C, that are arranged in a specific manner that produce a protein. And that protein, again, is what gives us our bones, gives us our enzymes and things that change our body chemistry and anatomy. But again, you can see here when there are changes in those letters and the ordering in the gene sequence that is carried on the chromosomes, that we may end up with a change with outcomes that are qualitatively and even quantitatively different, like chocolate cake and cheesecake. We're not going to talk a lot more today about the specific mechanics here, but again, a single gene change, for example, can cause sickle cell anemia or some of the other hemoglobinopathies. And again, that seems to be something, again, that hopefully if you had in biology class or you're fresh in your other training, doesn't have to make it complicated, but the idea that that change in a gene could change the product of proteins that would lead to differences in how we learn or how we develop. We know, as we've had the Human Genome Project and other progress in the science and genetics, these are ballpark figures, but again, in terms of when there are red flags, we know today that close to a little over half of congenital hearing loss, deafness, has a genetic basis. We know also of common loss combined with vision loss tending to be at older ages, and retinitis pigmentosa has a genetic basis. And again, we might say there's really a range of figures, but I would say at least 25% of children with autism, we're going to find some level of genetic change. And again, that's why we talk more, and certainly with the teamwork with genetic counselors, about the possibilities, not necessities, but counseling to then offer options to people of genetic testing. So again, for a family, genetic testing, again, can lead to a level of screening for relatives who might be similarly effective or have early intervention. Concern about family planning and chances of recurrence, and help the family plan in terms of the medical implications for the future. Again, I've mentioned the possibility of targeted treatments, monitoring for other health concerns, and again, being proactive and ahead of time in terms of complication that might be serious. And then clearly one of the most important things are getting families together around diagnoses. We talked earlier at the clinic around Down syndrome support groups, for example, sickle cell support groups, et cetera, and connection with other families, understanding and knowing. And for many families who also may be asking questions about why has this occurred in the family, or even addressing issues of being told somebody did this or something, that genetic basis we don't think of as blame and guilt, and as a way to then say, we understand this a little bit better, and knowing may be able to be helpful to the child and family. So at 2 months of age, again, Dr. Brown did a wonderful job of reviewing the milestones. I'm not going to spend a lot of time on this part of the slides, but let's just say a child who's 2 months, born at home. The father said the baby is not reacting to loud noises or responding to voices. And unfortunately for the baby born at home, I know there are mechanisms to make sure that screening that we would normally do as newborn screening is done when they return to the provider, even though it would not take place typically at home. The pediatrician or pediatric provider realizes that the baby's never had a hearing test. Family doesn't know that there are other members of the family with hearing loss or deafness, or really have any concerns about exposures during the pregnancy. But again, this child goes to the audiologist, speech language professional, and is found to have hearing loss in both ears. And this is the 136 EDDI program, again, that we want children to have early hearing screening, and then before 3 months, a hearing evaluation, and then at least by 6 months, early intervention. In this setting, again, over on the left-hand side, you could see a variety of causes. We know vaccines have made a huge difference, rubella and all being the major one, and all back in the 60s, that led to an epidemic of deafness, hard of hearing, but you can see other different causes there. but we know there's a little increase in hearing loss and Down syndrome. And then this particular child that I was thinking about has Usher syndrome. And Usher syndrome is one that combines not only typically some level of congenital hearing loss, but also then over time, and particularly in adolescence, the development of retinitis pigmentosa, and again, a visual component. In that setting, again, learning about a dual sensory loss early on in life can help in terms of the intervention and the services that are available to children in terms of their communication. Again, it's an autosomal recessive condition, and again, is relatively rare, several different types, et cetera. But again, the collaboration of the team, as Dr. Brown mentioned, can lead to the kind of intervention and supports for that child and family that can lead them to have really much better outcomes. At 6 months, again, here are some of the milestones. I'm just going to mention a case here where the child came for the 6-month well baby visit, and mom had concern about the cognitive milestones. The pediatrician also, who'd been following the head circumference, noticed that the head circumference was progressively smaller than normal, and so had gone from a higher percentile to a lower percentile. Again, what we would think the provider team would do was follow the head circumference, take a family history. I would, as a geneticist, measure the parents' heads, and again, take a history to go over possible exposures, physical exam, and again, in the absence of smaller parental head size or exposures like Zika or rubella in the unvaccinated, consider a genetic cause. Also, fetal alcohol syndrome is one of the conditions that can have a smaller head size, or it can be familial, but we have a growing number of genetic conditions we know that can be responsible for microcephaly. This child has Cornelia de Lange syndrome. Clearly, if it had this significant limb anomalies, there would have been concern or a red flag raised earlier on. But again, there are children who have minor limb anomalies rather than as extensive as here. And as an example, early on in care, a genetic diagnosis might anticipate the airway problems, as that can also be involved in this condition and could lead, preventing a complication at surgery that otherwise would make a child who again, had significant microcephaly, cognitive delay, and orthopedic problems have yet then another condition that they didn't have to have if we didn't handle the airway appropriately at surgery. Again, I think in the interest of time, Dr. Payne, I'm not going to read this whole slide, but we will make these slides available to you. These are children who are smaller, again, can have a specific genetic diagnosis made. There is a spectrum, as there are for many conditions. We often see first and identify first the most severe or serious or complicated of conditions, and then learn later that maybe even a parent has the condition or a sibling has the condition and is less severely involved. Again, going up to the 12 months age, and this is probably the one I want to highlight the most, that if I think of what is most likely to get to a genetic diagnosis is not only the presentation early on of birth anomalies or newborn screen anomalies, but regression later on. And what we really want to do is make sure we're not missing signs of regression that might, with treatment or prevention, be reversible. That's why we have the newborn screen, to address things that can prevent death, morbidity, et cetera. This is a young girl who had been starting to grab toys, saying a word or two and pulling to stand, but now the skills are leaving and not present. So in this setting, the child is found to have Rett syndrome. Again, this is a relatively rare neurologic condition, but it is this loss of milestones and regression that really has us concerned. Now, we don't have a magic pill or an immediate treatment for this, but what that diagnosis can often do is explain and see and connect with what has been helpful to other children in their therapies. And now today we have the advent of clinical trials as well. We're connecting with other families, connecting with researchers, the pediatrician being part of a global community as well as a local team to help with the rehabilitation of this child and not lead to more serious outcomes that would occur otherwise. This condition you can see here, this is what we call an X-linked pedigree. So again, boys can have this, but often because it's on the only X chromosome that they have, may have more significant morbidity or even mortality. And then I think I have one more example before we have Dr. Payne on. And again, this is a 2-year-old with significant speech delay, evaluated as Dr. Brown indicated would happen in this setting, and referred to genetics and found to have Fragile X syndrome. Fragile X syndrome, again, is one of our relatively well-known conditions. Again, it is X-linked, and again, no cure, but the genetic diagnoses can help the family, again, know what to expect, know what's worked in terms of educational strategies, specific medications that may work better or not, as well, obviously, as counseling and anxiety, aggression, and ADHD. And again, may impact because women who are carriers for this condition may have primary ovarian insufficiency, and grandfathers, that is, the grandfather of the child, since this is X-linked, may have been diagnosed with Parkinson's or some other neurologic condition and actually have a form of Fragile X called tremor ataxia syndrome. Again, clinical trials going on here. And then I think I'm going to actually skip my slides on this. They will be available to you because I understand, Dr. Payne has a specific example from our own practice, but in the neurologic category, I think is really where whether it's seizures or, again, some of the regression syndromes where genetic understanding, testing, potential clinical trials, new drugs, change of treatments, and seizure meds have really been made just a great difference and are helping us in our understanding of how to best help children in their rehabilitation.
Thank you. Good afternoon. I'm Mitzi Payne. I'm down here working in St. Thomas right now, so I'm glad to be a part of this group as well. I have a patient case I wanted to share with you all that was seen back home in West Virginia. And I'll have to give you a little neurology background to kind of understand the importance of how genetic testing helped us with her diagnosis. So we'll just kind of dive on in. So she was a full-term baby, but started having seizures like instantly after birth. And there was even some question of perhaps some seizures in utero, like right before birth was occurred. Oftentimes in that case, the mother might report like hiccups, but they're not hiccups, they're repetitive seizure activity. So we had kind of been worried that the seizures had been going on for a while. There was no birth trauma or evidence of like low oxygen, APGAR scores were good. So we didn't think that the seizures were a case of brain injury. The seizures were myoclonic, which is rather rare in the neonate seizure world. And myoclonic is just and I can demonstrate, like a brief jerk. It's almost like an exaggerated startle. But when we have the EEG, which is the brainwave test on the head at the time, it shows an epileptic discharge, whereas if it was just like a normal startle, it would just show a normal background. So that's how we kind of put it together. In addition, her overall background activity is what we call burst suppression, which is like these spikes and then it's flat. And so that's also not normal in a full-term baby. The picture on the bottom right is a normal newborn EEG. The one on the top is abnormal. And so the one on the top is pretty much what hers looked like, but she also had some of these myoclonic jerks, which ended up being seizures as well. So when we see this pattern, the first thing we usually think of is something called non-ketotic hyperglycemia, abbreviated NKH. Now it can be many, many other things, but that's kind of the number one differential on our list. And to diagnose that, we have to do a lumbar puncture, get the CSF sample, and then send it off. And that's a send out lab. So it takes about 1 to 2 weeks to get back. And we're looking at amino acids in the CSF. And glycine is one of those amino acids, and glycine is elevated. But while we do the LP and take the CSF, we're also going to look for other things like glucose levels, protein levels, white cell count, other things in the CSF, just to make sure that it couldn't be other things. Because as I said, there's many things that can cause this. So we kind of rule that out as we're doing the workup for NKH. So at that point, about NKH. So at that point, we felt like she was a suspected NKH case, and we were giving her lots of seizure medications. At one point, she was on 5 different medications, and nothing was really helping. So one of the treatments for NKH is called the ketogenic diet, which is high fat, low carb. And that's not always the healthiest thing for a newborn baby. As you can imagine, newborns have a diet that they're supposed to have. And when you cut out the carbs and give them only certain fats and proteins, it can definitely affect their overall health and growth. So we weren't sure if it was like, did we need to do this? Of course, would we do it to help the seizures? Yes, but like, what's the downside of all of this? Other treatments for NKH are sodium benzoate and dextromethorphan. Those usually aren't started like in the very early neonatal period either. So we were just kind of stuck, like, what do we do? So while we're doing this, the CSF comes back and says that the glycine levels were normal. So we're like, okay, so it's not NKH. So we did start the ketogenic diet for a couple of days. So by the time the results came back, we stopped that. The ketogenic diet had not helped the seizures anyway. So, you know, it wasn't helpful. And so we ordered genetic testing. And where I am in West Virginia, especially at this time, we weren't able to do, well, we did the screening genetic testing that was all normal, but we weren't able to do more in-depth testing. And so she had to go out of state for that. So this is definitely a case where it was hard to see the baby leave our hospital for further genetic testing when we knew like we were taking good care of her and we could really keep doing what we were doing and she was getting good care. It was just that missing link of that extra genetic test that was ordered. So she had that done and it came back, she was a STAMBP gene, which is, there's a syndrome called microcephaly capillary malformation syndrome. So this was helpful for us because of course it changed our management. We didn't have to do the ketogenic diet. We didn't have to look at doing all the other treatments that are given for NKH. Now, unfortunately, this is a very rare syndrome. And as genetic testing is done more and more, likely more children will be picked up. So we don't really know a prognosis for this. We also don't really know exactly which seizure medications would help for her, but we do have a diagnosis and we were able to rule out one of the other syndromes that would require a specific treatment. So this is microcephaly capillary syndrome, and it basically is how it's described. They have microcephaly and cutaneous capillary malformations. Now, when the baby was born, she didn't have these capillary malformations, but as you may know, newborns don't always have their quote unquote birthmarks until after birth. And these babies have early onset intractable seizures. And so few cases are identified and there's no specific treatment that we know of. Okay, so that was my case. And you want me to go to the next? Okay,
Thank you. No, I don't know, Melissa, if questions have come in, again, we whizzed through lots of material here. Maybe is there anybody of our speaker group who has a question at all or something that was unclear, or Dr. Brown, is there something how when you participate, for example, in the early diagnosis of deafness, hard of hearing, how today might genetics come in here? And then part of why we're here is to figure out how to make that, let's say, optimal.
Right. So I think for our population here, to know where to go, to know that when we're thinking about deafness and some of the other syndromes, that it all boils down to us being able to monitor for certain, I guess, like skills, milestones,
Sure.
and then be able to refer and know where to refer. There was one that you didn't mention, but I was just wondering, charge syndrome.
Sure.
And I was just wondering if you could
Yeah,
talk
so again, CHARGE is an acronym, and also it's an acronym. I see coloboma of the eye, heart anomalies, no, atresia coani, they're backwards is the problem, the way they're sort of done backwards. Yes, then renal genital anomalies and ears. And we actually have, as people who do careful exams around genetic syndromes, we try to make a clinical diagnosis, and that was what it was for many years. And today we have a molecular diagnosis for that. It is a dual sensory problem oftentimes between both hearing and vision, depending on the coloboma as well as the extent of the internal ear involvement. But again, children in one state, for example, there's a special dual sensory, I can't name at the moment, but again, it puts you down a track for prevention and monitoring that really can be quite different. And again, paying attention if the hearing challenge is identified at birth, while AAP does continue to suggest ophthalmology, obviously involvement if you're concerned about dual sensory defect. The goal there would be, again, the kind of habilitation resources for both communication and vision in the school setting, as well as early monitoring identification of the other anomalies. Again, my understanding here on the Virgin Islands, and I unfortunately didn't go to St. Croix, is with the neonatologists and the providers, guessing they're nurse practitioners as well as pediatricians in, for example, the nursery and the newborn care unit. The part we're learning about now is sort of how to pull the genetic piece in. And Dr. Payne identified as well that that child was transferred, I think from Marshall, correct? Don't have to know where it was transferred, but what part of our goal in thinking about telegenetics and connections otherwise, obviously the non-ketotic hyperglycemia, I mean, we would say that potentially goes, to a very advanced center if you're not making ground with it and all. But we would hope to be making strides over the next short to longer period of time and working together, that the genetic testing piece could be easier and something that wouldn't require necessarily transfer of the child. We do that between two hospitals within the Hopkins system now, where we have teleconsults and e-consults from one NICU, but not a NICU that all of the specialists go to. So they, cardiologists, the neurologist, endocrinologists, geneticists, et cetera, do that all electronically and can provide then follow-up telehealth counseling. The testing can be done in coordination with the genetic counselors and all. Again, and I think, as you know, for many things where there are smaller populations, our experience on the Indian reservation was there were things we knew that needed to be sent, but today we try to keep families in their home hospitals with closer to their relatives and families as much as possible.
And I think understanding, we don't have to memorize
All the letters and
right,
yes,
right.
yeah.
As long as they, and even if they have one child in their care, or if it's a supervisor who's talking to employees at a particular center, right? That it may be just to understand that particular, do your homework
Yes,
as well as
yes.
teachers would,
Yeah.
understanding what can I expect to see,
Yeah.
and understanding those milestones, what those domains are.
Yeah, and on, I guess I should advance the slide here. I
Well,
put my glasses on. Yeah, the
Before you
gems.
go on, in the middle of the screen, there's a resource called GEMS.
I'm
That's okay.
sorry.
That's okay. Which is really focused on how genetic conditions can be successfully handled and integrated into the school experience. So that resource was created by one of our sister institutions in the Northeast states, but it's a really great place for educators and therapists to be able to put in a diagnosis and see really school specific materials. But you're not going to find every diagnosis there because these diseases are rare. And so, the NIMAC website is on there. There's other resources for genetic conditions, but we want you to see us at NIMAC as a resource too. So we will make sure to give you our contact information at the end, as well as Dr. Payne's, because for children that are here that have some sort of developmental delay or neurological concern, we're really happy that Dr. Payne is coming now to both St. Croix and St. Thomas, and wanted to make sure all of you knew that that resource is available. So share that. On the next slide, we do have the survey again. So the reason that we do this at the beginning and at the end is just to see, if our conversation today has helped support people in kind of understanding if genetics is relevant to what you're working on. So if people could answer those questions quickly again, it really helps us kind of look at that before and after to see how things are going. And I'm going to try to repaste that in the chat for everyone, because I know it is a lot easier when you can just click the link.
It was up there. Now I should do it in here. There, you swimming.
They need it down here.
Yeah, there. Don't move so much. There, you got it. Can you see it?
Yeah,
Up
I'm
here.
trying to paste copy.
Oh, I know.
I'll get it. I'll put that link in on my phone so you can see it. But on the screen right now, you can see the phone numbers for the clinics that Dr. Payne has, both in St. Thomas and in St. Croix. So please write those down, and we will make the slides available so that people will have those And then Dr. Bertha and Maria Isabel and myself can all be reached through NIMAC. There's a general NIMAC email there as well as our website. So if you want any of us, you can reach out there and they will get a hold of us. So we really do hope this is just the beginning of a relationship where we can continue to provide resources and support. And we aren't in a rush. So if anyone else has any questions, we're happy to answer things if you want to put in the chat. And we're also happy to answer things later on if people have questions. So I definitely want to thank Dr. Brown and Dr. Payne and Maria Isabel and Dr. Bertha for all being here. We're so thankful for, as Joanne said, for the warm hospitality we've received throughout our whole time here. It's been really overwhelming, I think, how warmly we've been treated. So huge thanks to everybody. And please, if anyone has questions, please feel free to ask them now. Yes, please. Yes.
So in the very beginning, Dr. Brown and I comment, okay, the word travels fast in the territory. So we want word to travel really fast about today. So if you feel that there are colleagues or even families who would like to hear this for whatever reason, reach out either to us, to Dr. Brown, to Dr. Payne, or to anyone, and let us know, because we will be happy to redo this.
As it was recorded as well. So
Exactly. So it's recorded. And if you feel that, you know what, there's a topic that I would like, I just saw a child with this, tell us, because we are happy to do this. And again, we're very thankful for Dr. Brown to include us in the series of webinars. So thank you. I just wanted to add that. Thank you very much.
yes, please, Cameron.
Yes. Thank you.
We have a whole system of moving chairs around over here that you're not seeing.
So yes, as Maria Isabel mentioned, this is a part of the ACT Early VI Professional Development Series, all things early childhood. And next week, we're going to, I didn't want to send the flyers out because I don't want to get confused with what we're doing this week with NIMAC, but we will focus on identifying the signs of autism and family conversations. So I will send that out on Monday. And remember, that's also in collaboration with my colleague who is an audiologist at Georgia State University. So I guess at this end, I would want to thank NIMAC for being here. Maria Isabel and I have been working together for many years now, I think at least five years. And it was, I believe it began when we had the health brigade, the Zika health brigade. We were focusing on Zika and helping families, I guess the babies who were, it was also in partnership with the University of Miami, a colleague of mine there. And it was a HRSA, we had multiple HRSA grants at that time. And it was another organization that Maria Isabel was working with. And we were trying to help families identify, I guess, any delays, disabilities as a result of the birth defects that some of them were experiencing, the moms. We found that babies were being born, even those who were not diagnosed with Zika, but if they were exposed, that later on they were demonstrating birth defects and developmental delays and disabilities. So that's where that work began as well. So, but I'm happy to be here. And if you need to get in contact with me as well, I'm karen.brown@ubi.edu. KAREN.brown, no E, just like the color, @ubi.edu. Thank you so much for being here. And yes, if you want a certificate, just send me an email and we can see what we can do and present a certificate. You're welcome.
Thanks, everybody. Really appreciate it. We look
Take
forward to
care.
working together. Take care. Can't get the mouse.
Okay, there we go.